Hi, my name's Lori Sherman, and I'm the owner and administrator of Providence Senior Living in Alpharetta, Georgia. Our website is providenceal.com, and we love to take care of seniors, so please go check us out. Today, I'd like to talk about treating dementia in the elderly with antipsychotic medications. Behavioral and psychological symptoms of dementia can include aggression, agitation, loss of inhibitions, delusions, and hallucinations. These symptoms can be so severe that the patient's safety and well-being are at risk. Antipsychotic medications should not be prescribed as a first resort. Behavioral and environmental interventions can be extremely helpful and may resolve the symptoms in the lesser cases of dementia. Examples would be the caregiver changing their tone of voice to be more soothing, or offering rewards in exchange for the patient's cooperation in daily routines. Sometimes adding or removing stimulation to or from the environment can also be very helpful with dementia symptoms. These techniques should always be tried first before using antipsychotic medications. The Alzheimer's Association states that antipsychotic medications are overused 2/3 of the time. So there's a great deal of oversight around the use of antipsychotic medications. In particular, Medicare watches how often they're used in nursing homes. This same level of oversight, however, does not apply in people's private homes, nor does it apply in assisted livings, which is state regulated, not federally regulated. Antipsychotic medications were first used in the 1950s to treat schizophrenia. These medications help patients lead a more normal life by alleviating symptoms of paranoia and hallucinations. Antipsychotics do not cure dementia and they do not cure schizophrenia, but they do lessen the symptoms and they reduce anxiety, agitation, and restlessness. The original antipsychotics had a lot of bad side effects like tremor and abnormal movements, which led researchers to try to find improved drugs. We now have a new class of drugs called atypical antipsychotics to treat dementia in the elderly. Some of these drugs are Abilify, Zyprexa, Risperdal, and Seroquel. These are the most common atypical antipsychotics that we see in use in the elder care industry today. These drugs began to be used off-label to treat dementia patients in addition to schizophrenics and have been found to be highly effective in managing negative dementia behaviors. This use of atypical antipsychotics to treat elderly dementia patients is still not approved by the FDA, which has led to some controversy in the elder care industry. Research indicates that patients on antipsychotic medications have double the risk of stroke. This goes from about 1% in placebo-controlled patients to 2% risk of stroke in patients receiving antipsychotics. These are elderly patients. It's still a pretty small risk, but it has to be weighed against the possible benefits. When should these drugs be used? Dementia symptoms can be severe. Hitting, biting, kicking, spitting, inappropriate undressing, shouting, and the use of obscenities are examples of behaviors which can be so disruptive that they can't be tolerated by caregivers. These symptoms can make it difficult or even impossible to keep the dementia patient clean, dry, well-fed, and engaged in activities. It's important to remember that these symptoms mean the patient is suffering from high anxiety and agitation. And suffering should, in my opinion, be relieved medically if behavioral and environmental interventions are not sufficient. A clinician may opt to prescribe atypical antipsychotics in these cases. Getting a patient regulated takes medical and nursing expertise and almost daily follow-up. Dosing is usually started very conservatively with very small doses, which are eventually titrated upward to the required level. It may take 2 to 4 weeks to achieve the desired level of control. In some severe cases of dementia, it can take 6 to 8 weeks. Patience is required. During this period, the patient should be observed on a 24-hour basis. This can be done in the patient's own home if there is a caregiver present around the clock, or the patient could be admitted to an inpatient psychiatric facility. The downside of the latter option, the psychiatric facility, is that Medicare frequently will not pay for the amount of time required to stabilize these patients inpatient. So a lot of this stabilization is being done at home or in assisted living facilities. Behavior changes should be reported to the clinician every 5 to 7 days so that dosing can be reevaluated and adjusted until the patient is stabilized. If there is not enough improvement, the clinician may add another drug like a mood stabilizer drug, or they may discontinue the current antipsychotic and try a new antipsychotic. There's no way for a clinician to know beforehand which antipsychotic is going to be effective. Sometimes several medications have to be tried before the right one is found. There are some side effects of atypical antipsychotics. Most of the side effects are mild. Many of the side effects, like oversedation or drowsiness, disappear within a few days or weeks of beginning the medication. That's important to remember because a lot of family members who are supervising the care of a senior get very alarmed and concerned when the resident seems to be oversedated. But those side effects generally disappear after a few days. So patience is required, and we just have to keep the patient safe from falls during that period of time because the oversedation can make them temporarily a higher fall risk. So we should take additional precautions during those periods of time of stabilization. I want to summarize the importance of a holistic care plan for the patient with dementia. It takes good assessment, takes nursing oversight, experience, and understanding of the drugs. Typically, you're not going to be able to take your loved one into the doctor every 5 to 7 days to have the doctor check the patient out to see if the recent drug change helped. So a lot of this is done at home, and it's the caregiver that has to be trained and observant. It's best if it's done by a nurse, but that's just not always possible, unfortunately. We should make sure that a patient's behaviors are not really just that patient's attempt to express an unmet need, like going to the bathroom or just being bored. Sometimes those two things in a dementia patient can trigger a behavior like shouting. You don't necessarily need to prescribe an antipsychotic if all they need is to go to the bathroom. Antipsychotic medication should never be the first line of defense. Behavioral and environmental interventions should always be tried first to manage behaviors and probably continued even after the medication therapy starts, if it does. Caregiver training is essential. Make sure the caregiver knows how to correctly interpret a resident's behaviors. They may not be able to explain what they need, but if a caregiver is tuned in and reasonably educated and trained, they should be able to understand and at least try some things out. Let's go to the bathroom. Let's do a puzzle. Let's have something to eat. That may meet the need and solve the behavior, and you can avoid using antipsychotics altogether. If you do need to use them, talk to your clinician, your nurse practitioner, physician's assistant, or your family doctor about using antipsychotics. And if you need any help, give me a call. My website is providenceal.com, and I'm here. I'm happy to help if you need any advice. Thanks for your time today, listening to my video blog, and stay tuned and come back for more. Bye-bye.